Despite women representing half the population of Canada, there remain a lot of questions surrounding their health needs. Is a lack of knowledge hurting women's health? And should Ontario invest more money into research? Joining us to answer these questions, we welcome in St. Albert, Alberta, Carmen Wyton, Chair and Founder of Women's Health Coalition of Canada. In the nation's capital, Dr. Amanda Black, Professor of Obstetrics and Gynecology at the University of Ottawa. And in Ontario's capital city, Christine Faubert, Vice President of Health Equity and Mission Impact at the Heart and Stroke Foundation of Canada. Welcome to you all. Carmen, I wanted to kind of start with you. Can you give us an idea? I mean, if you were to say it in a few words, how would you describe the current state of women's healthcare across Canada?
Women's healthcare, unfortunately, is declining. It's declining in importance, it's declining in funding, but the needs of women are increasing, and so women are being left behind. And nobody did it on purpose, but now is absolutely the best time to challenge it and to think differently and to encourage women to stand up for themselves as well, because it's not going to get better by itself.
Well, you know what you said about women's needs are increasing. I wanted to get into some stats from your organization about what it looks like here in the province of Ontario. Billing rates for common gynecological procedures are up to 50% lower in Ontario than in provinces such as Alberta and British Columbia. Gynecologists earn significantly less than their surgical colleagues. Obstetrics and gynecology share a single funding pool, leading to obstetrics being prioritized over gynecology. Wait times for gynecological care are unacceptably long, with some tertiary centers having wait lists of 800 to 1,500 patients. The most complex cases face delays of 2 to 3 years for surgery, leading to serious health consequences. Gynecology remains the only specialty that has seen a decline in spending over the last 8 years. Carmen, as founder of Women's Health Coalition, what prompted your organization to create this study?
The Women's Health Coalition of Canada actually started in Toronto, where I gathered with women who had uterine fibroids. And the common denominator among all those women was the amount of time that they had to wait to be taken seriously to get into treatment. And it was because so much of what they would convey to their healthcare professional was treated as normal, and they were sent home, or they were sent home with antidepressants. And so when you look at the inequities that are emerging, it's because women's health in primary care is overlooked and underserved. And so by the time they get into the specialist system, it's being overtaxed as a result. And so those things, the start of the Women's Health Coalition and the inequities we're seeing in Ontario and across Canada are it's a trend that we need to break. But it does kind of start with women's health in primary care. As you said in your notes, obstetrics and gynecology is a combined specialty, but then put into that also clinical care. And no other specialty shows up the way OB-GYN, medical, and acute care does.
Amanda, I wanted to come to you next. Carmen was talking about uterine fibroids. I actually went through an experience of being diagnosed with fibroids. And then I kept going into the ER for about a year, taking up resources from other people because I was on a wait list for 2 years for surgery. As a gynecologist, does this data align with what you see in your practice?
Yeah, I think there are a number of conditions that affect women specifically that probably don't receive the attention that they need as far as resources, as far as diagnosis, as far as access to care. So there are many common gynecologic conditions that could really impact a woman's quality of life and their ability to be full contributing members of society. So things like conditions such as fibroids, certainly heavy menstrual bleeding. So when we look at time lost to work due to issues around the, heavy menstrual bleeding, patients with endometriosis who are suffering from endometriosis, who not only face long delays in diagnosis of endometriosis, but once that diagnosis is made, long wait times for access to care. And we know that, for example, women with endometriosis, they report significant effects on quality of life, including their ability to work. So I think it's up to 47% of women with endometriosis report work impairment. And, close to 20% of them have missed work in the past because of pain or other symptoms related to their condition. And that leads to lost productivity and ultimately a greater strain on the healthcare system. And, a significant aspect of our workforce not being able to fully participate to their highest potential.
And something you said, Amanda, kind of stood out for me is that pain, because I think women are still expected to show up in all aspects of their lives, no matter what is going on with them. And Carmen, we know historically women's healthcare has been under-researched and underfunded. Where are we sitting at now?
Well, in terms of underfunding, there was a study done, sexism in surgery, and we can do a head-to-head review of men's treatments, men's surgeries, and women's surgeries that are absolutely comparable. And in almost every province, there's going to be greater compensation for men's procedures. And so, because of that, what it means is that across the whole spectrum of treatment, the system is going to favor other specialties. The system is going to favor men's health over women's health. And so that really is the trend we need to turn around. And then on top of that, if women aren't um, challenging their healthcare provider that the symptoms they're experiencing, whether it's heavy menstrual bleeding or pelvic pain, PCOS is a very complex condition that if women don't really take authority of that health experience and demand more of their system, they are going to sit in blah wait lines. They are going to be waiting for surgery and their disease or their condition will worsen. And so we have to not be satisfied with that any longer.
Christine, when Carmen said that the system is going to favor men's health, I saw you nodding.
Yes, absolutely. And I think just going back on the research funding, there's definitely a persistent lack of awareness and understanding around women's heart and brain health overall, just even women's health in general. So we know that women have historically been underrepresented in heart and brain health research and just in clinical health research overall. There's a very, I would say like shocking, but stats around the representation of women in clinical trials. We know that over the years, only two-thirds of participants in clinical trials have been men. So it means that a third have been women. So that's a gap, and what it means to it when women are actually included in clinical trials. It doesn't mean that an analysis of the results by sex and gender is conducted. So that means that the research results, they're generalized to men and women overall, and when in fact it actually might represent more men than women. So there's a lot of catch up to do in terms of really understanding women's health, women's heart and brain health. What put them at risk, what are the specificities, and what type of diagnosis and treatment are required to really help women achieve health outcomes that are positive and reaching quality of life.
I mean, even something as when we talk about the signs of if you're having a heart attack, I think we think of certain things, but those things are related to men. Can you talk to us more about that, Christine?
Yes, absolutely. So we know there's actually shared symptoms both for men and women. So the typical ones that we know around, chest pain, that kind of thing. But we know that women will tend to also present with different symptoms. And unfortunately, those are not always known or seen when they actually present to the emergency or when they have conversation with their family doctor. So women tend to have, for example, more symptoms that seem a little bit more like anxiety or stress. So they will have, kind of like pain or things happening in terms of their jaw, their upper shoulder, upper back, or even some sort of, belly ache, that kind of thing. So oftentimes what happens is that women will try to describe what's happening to them, but then they're sent home probably with kind of like a basis around, maybe you're just having some sort of anxiety or depression. So that becomes really frustrating. And unfortunately, this is just because it's not well known at this point yet. What are those women-specific symptoms of a heart attack?
When you said that the symptoms could present themselves as anxiety and stress, I think we're all women, so I think we've all had maybe a situation in our personal lives when you were going through something and it was kind of just shrunken into, well, it could be anxiety and stress, when it could be something more serious. Amanda, how is the medical system in Ontario failing women?
Well, I think, there are some areas where we are doing well, and certainly in comparison, but I do feel that we have a lot of work that needs to be done. We're talking, first off, just about access to care. So access both to primary care, which we know is an issue for many people in Ontario, for thousands of people not having access to a primary care provider. We're also talking about access to gynecologic surgeries and wait times associated with that. So not only the time it takes to see a specialist, but then the time it takes once you see that specialist to actually be scheduled for a procedure. And knowing that in many cases, we've innovated as much as we can to try to move certain things out of main operating rooms into outpatient facilities, trying to do things that day surgeries that were previously done as inpatient surgeries, but at some point you reach a max. And I think there needs to be that recognition that these are conditions that affect a significant proportion of the population. And we want to be able to get these people back into their lives and be productive members of society. I think one of the challenges that we have is that we don't have reliable standardized data to look at how we can help improve our health outcomes. So there's no national framework or even a provincial framework for collecting or sharing consistent data about a number of women's health issues, including pregnancy outcomes, maternal morbidity and mortality, or some of the more common gynecologic conditions that we see, such as endometriosis, fibroids, pelvic pain, even PMS type symptoms or menopause symptoms. So how we're failing in that is that we're not investing in the structures that we need, or the systems that we need in place to be able to identify even what the issues are, the magnitude of the problem, and so that we can go about addressing this appropriately and making sure that we've got the resources adequately allocated. So I think where we're failing is access to care, wait times, people now having to go outside of the province or outside of the country to have to access care, but also just not really having a good understanding of what the problem is, because we haven't invested in the data networks or the systems that we need to be able to really address.
And I think what I'm seeing that's happening is that because we don't have that, a lot of people are turning to social media for those answers. I want to talk about that, but because you mentioned data, I want to go back to Christine and talk to you a little bit about the work that you all do. How did the Heart and Stroke Foundation start focusing on women-specific research?
Yes, well, as I mentioned before, there was such a gap in terms of knowledge around women's heart and brain health, which is, where we're investing our research and doing our work. And I think it was coming from a perspective too of, from an equity perspective. I know Carmen mentioned that earlier, but there's right now, because of those gaps right now, women are not receiving the care that they deserve. And, women are dying prematurely, and they're, not enjoying, to the fullest their life. So there's many things to actually do in terms of research. That was critical for heart and stroke, because that's a critical thing we do in terms of our mission, our mandate. We've done also a lot of awareness. So these were kind of like the main drivers at the beginning, is just helping people understand that women's heart and brain health, it's not just something that happens to men. So heart disease is oftentimes associated with men. So just raising awareness around, no, this actually impacts women as well. So that's a critical thing that everybody needs to understand and to be aware of. And then just building that whole, base of knowledge to really drive our care is provided, so clinical practice, care models, treatments, and to really lead to women's positive outcomes.
Carmen, I wanted to go back to something that Amanda was talking about, the fact that we don't have any kind of like data across the country. And so out of frustration, a lot of women, if they can't get an appointment with a gynecologist, in order to do that, get an appointment with a gynecologist, you need a family doctor. We know there's a family doctor shortage in this country. So when you can't have access to that, you turn to social media. Social media is not always the place that has the best info, but sometimes that's where people can find a community and maybe information that they're in desperate need of. So how do we avoid that moving forward?
Well, Dr. Black is absolutely right. One of the things that will be core to the future of women's health is Canada, the government of Canada prioritizing a women's health framework. And if you put it into the perspective of the diabetes framework that they brought into place, I think it was maybe 5 years ago, it's a very similar type approach. It's a very large population with complex, unique needs. In the case of women's health, it changes from as they go through the various ages and stages of their life. The absence of the framework, or rather the installation of the framework, could drive some of those awareness factors. You'll never get rid of social media, but there needs to be a better network of qualified resources that patients can rely on, and that would be the advantage of a framework that was federally enabled and then instituted across provinces in Canada. And so the Women's Health Coalition is committed to working on that with every province, making sure we have qualified resources, and then let's track them in social media so that when people turn to social media, they can actually navigate their way through valid resources. And so, yeah, that's what we need to do, and keep them from going stateside.
Amanda, could social media be a positive in this situation?
Absolutely. I think we have to look at both sides. So there's the positive and the negative aspects of social media. And certainly we have seen ways in which women have used social media to advocate for their own health. So, I'm looking just at the specific example of pain with IUD insertions or gynecologic procedures. And I think there was a real push from social media for the healthcare profession to address that. And I think we have now done that. And that's that push from women themselves. And I think that social will actually helps breed political will, or will at the level of the policymakers. So absolutely, I think there are positives to that. Similarly, as Carmen mentioned, we need to make sure we combat disinformation that's out there and ensure that people do have access to the best possible information that they have when they're making decisions about their health, or just exploring what they might be worried about when it comes to health. And the Society of Obstetricians and Gynecologists has a number of excellent websites on menopause, endometriosis, HPV, pregnancy, often in collaboration with other organizations in Canada. And those provide really good informative evidence-based information that hopefully will address the concerns that people have without some or questions that they have without worrying about some other maybe ulterior motives that there may be as part of a social media platform or other websites.
Well, speaking of disinformation, we are going to play a little myth busting in a moment. But for people who might have missed it, women before were getting IUDs without any pain management, and now it's kind of changed. But Amanda, you helped to get Bill C-64, the Pharmacare Act, passed last fall. Why is this a step in the right direction?
Well, I think for everybody who's not familiar with that, so Bill C-64 was introduced last February and received royal assent last October. And that's a national framework for pharmacare with the first essential medicines that are being covered on that being diabetes medication and contraception. And that is a huge step forward as far as women's equity in this country. When we look at the rates of unintended pregnancy in Canada, it's up to 40% of pregnancies are unintended. Many of those because people can't access contraception, or maybe they can't access the contraceptive of their choice because cost is a barrier. And the cost that sometimes people will argue, well, can we afford to do that? Our argument is always, well, you can't afford not to do it because the cost of unintended pregnancy alone, just the direct cost, is $320 million per year, not factoring in the longer downstreams effect for the society and the individual and the children themselves. So I think it's a huge step forward. Cost modeling is showing a significant cost savings associated with that, both when we look at cost modeling in BC, cost modeling nationally, and cost modeling in other countries. So it's a huge step forward. Now, what we need to do, we're at the point where it's proceed royal assent. Some provinces and one of the territories have signed on, but we need to encourage our provincial governments, including our provincial governor in Ontario, to sign on to bilateral agreements so that we can ensure that access is not dependent on where you live or your income. It's something that all Canadians have access to, and that ensures that we have equitable provision of contraception in Canada, which will provide women with more opportunities.
Christine, I saw you nodding.
Yes, absolutely. Yes, and I was just talking to our team in Ontario. I think thinking about just building on the medication piece. We know that in Ontario, nearly 1 in 5 women in Ontario do not have access or do not have any drug insurance plan. And they're also more likely than men to actually skip filling their prescription due to the cost. Their overall drugs, gaps in terms of drug coverage will disproportionately affect women compared to men, especially women from low income. So I think, yeah, absolutely, there's lots of gaps on that front, and that needs to be addressed.
We can't have this conversation without talking about cervical cancer. According to Government of Canada and Canadian Cancer Society, cervical cancer incidence has increased in recent years and is cited as the fastest increasing cancer amongst women. Carmen, what are some ways in which we can reduce these cases?
There's one core response to that trend that we don't want to see, and that is switching wholly to HPV primary screening. And we are beginning to do that in Canada. We're really not doing it fast enough. There's still, some provinces that say they're transitioning. Some have transitioned to self-sampling, but they're not doing the other stuff that needs to happen in between. Self-sampling is a choice for sure, but it's not the only option or always the best option. So we have to switch to HPV primary screening so that cervical cancer doesn't even happen. And that really would allow us to eliminate up to 90% of the current cervical cancer rates could be eliminated if we focused on HPV screening instead of, waiting for a woman to present to her gynecologist with advanced disease. And so cervical cancer is preventable, and we need to embrace that, and we need to focus on HPV.
In the last 5 minutes, I wanted to go over some of the disinformation that we're hearing a lot online. Amanda, I wanted to start with you. If you can tell us if this is true or false. Naturally tracking your cycle is the safest form of birth control.
So I would say that is not true. Some people may opt to use natural family planning methods, including cycle tracking, as a way of monitoring their fertility. But as far as being one of the most effective methods of pregnancy prevention, it would not be high on the list, simply because women can have variations in their cycles for a variety of reasons. They may have other coexisting medical conditions. So natural family planning is possible to be using, but I would not consider that as an effective method of contraception for a lot of women.
Also STDs, right, or STIs? It doesn't protect you from that.
No, so none of the methods of contraception other than the condoms would protect against sexually transmitted infections, and so condoms protect against many, but not all STIs.
And Christine, this is just a myth, it's not me saying it, but this is only unhealthy older men have to worry about heart disease.
Oh, so absolutely not. And this is interesting, and this is I think what drove all of our work, for a few years now. It's interesting because nearly 40%, what we know from a study we did in 2021 is that nearly 40% of people in Canada, they do not realize that heart disease and stroke are the leading cause of premature death in women. And we know that there's a number of conditions, including heart failure, stroke, and others that are actually more prevalent among women. So that's definitely something to raise more awareness among women, but also just people in Canada overall, including healthcare professionals.
And Carmen, all women experience painful periods.
That would not be true. But many women, one out of 3 women, will experience such severe menstrual pain and menstrual bleeding that it actually becomes life disrupting. It keeps them from social engagements, keeps them from family events. So yeah, 1 out of 3 women will experience severe pain and quality of life disruption. So partly true. How's that?
We have about 90 seconds left. I would like to give you all 30 seconds. It's come to, I guess, where we are right now. Women have to advocate for themselves, and it can be intimidating because doctors are authority figures. What can women watching do to advocate for themselves in the healthcare system as we have it right now? I'll start with you, Amanda.
Well, I would say we would want people to start with recognizing the importance of maintaining the sexual and reproductive rights that we have in Canada and Ontario. And I think there are a lot of things that we think are a given, and we just have come to expect it, but we've seen that that's not necessarily the case, and those rights can sometimes be rolled back. So encouraging women to still be vocal about the need for access to sexual and reproductive health services. So including contraception, including abortion services, including gynecologic care. I think that that's really, really important because, again, as we're seeing, things could roll backwards very quickly, and we need to be very vocal about the importance in our country and in our province of maintaining those rights.
And Christine?
I would say I think the importance of just recognizing that a lot of our heart conditions and stroke can be prevented for women and for men as well. But I guess helping women understand what their unique risks are for heart disease and stroke. And we know that women have specific risks, especially when we look at their life stages around reproductive years, when they had pregnancies, around menopause, post-menopause. So what Heart and Stroke is trying to do is really to help equip women with more knowledge, and again, knowledge that's evidence-based, to really understand what their unique risks are, and then what can they do in terms of taking action to really reduce or prevent or to manage their risk. And so one thing we do is we have a campaign right now. We've built some resources on our Women's Hub on our Heart and Stroke website to really help women advocate for themselves and just have the right resources and tools in their conversations with their healthcare providers.
And Carmen?
Women need to be encouraged to take authority of their health journey, and with everything that means. And that means seeking out information on health providers. The conventional system that's always been around isn't the only thing available. I know that our public health system is strained, but there are private health systems that are emerging that can help cover a gap. And so if women do have access to health benefits, there may be other options available to them. They can go to sites like the Heart and Stroke Foundation, where there's good information to help them navigate the system. But I think women have to not be willing to just sit back and let their health happen to them. I think they need to step up, talk to people, and go to find the resources on their own and act on them. They've got to own this, because that is what will make the system change.
Thank you all so much for your time. I think it's conversations like this that can spark awareness and lead to action and help a lot of women across this country. We appreciate your time. Thank you.
Thank you.
Thank you for having us.